Okay, I think we can start. Good evening, everyone. Welcome to the Asia Pacific Cardiometabolic Consortium live webinar. We're going to be presenting the hot cardiometabolic topics arising from the American Heart Association meeting earlier this year in 2025. And this session is supported by the Taiwan Heart Foundation, and many thanks for their support to stream this live. We have with us here three speakers and panelists. Today we'll have Dr. Kyung Hoon Cho from the currently at Monash University Victorian Heart Institute in Australia, and he's going to present the AHA presentation on the phase 1 trial of the CRISPR-Cas9 gene editing target for ANG PTL3 gene. And then we'll have Dr. Satoshi Kitahara from Kashiwa Kosei General Hospital in Japan, and he's going to present on the Vesalius cardiovascular trial, which is the effect of evolocumab in patients at high cardiovascular risk without prior MI or stroke. And then, and importantly, Dr. Satoshi Honda from the National Cerebral and Cardiovascular Center in Japan is going to provide some commentary on these two studies. And then together we'll have a robust discussion on these two important trials that were presented at the American Heart Association. My name is KKU. I'm from the National Heart Center Singapore, and I'm delighted to be a host this evening. And maybe with that quick introduction, I'd like to invite Dr. Cho, who will present on the CRISPR-Cas9 gene editing study. Dr. Cho, please.
Thank you, KK. Good evening, everyone. I'm Kyung-hoon Cho from Monash University Victorian Heart Institute. I would like to talk about phase 1 trial of CRISPR-Cas9 gene editing targeting angiopoietin-like 3. A major limitation of currently available lipid-lowering agent is diminishing adherence over time, as well as side effects. Angiopoietin-like 3 is an important regulator of lipid metabolism through inhibition of lipoprotein and endothelial lipase. Loss of function gene variants for angiopoietin-like 3 result in lifelong reductions in LDL cholesterol, triglyceride, and reduced risk of atherosclerotic cardiovascular disease. CTX310 is a lipid nanoparticle CRISPR-Cas9 formulation to induce permanent loss of function in the angiopoietin-like 3 gene developed as a one-time treatment for elevated LDL cholesterol and triglycerides. Angiopoietin-like 3 act as a key regulator in lipid metabolism by inhibiting two important enzymes, lipoprotein and endothelial lipase, resulting in increased level of atherogenic lipid particle, including LDL cholesterol and triglyceride. CTX310 is a lipid nanoparticle containing mRNA encoding Streptococcus pyogenes Cas9 and a single guide RNA to permanently disrupt the angiopoietin-like 3 gene. Lipid nanoparticles act as a vehicle that delivers CTX310 to liver cell. mRNA encoding Streptococcus pyogenes Cas9 tells liver to produce Cas9 protein, a molecular seizure. A single guide RNA guides CTX310 to specific spot, angiopoietin-like 3 gene. Finally, angiopoietin-like 3 gene is permanently disabled. Single ascending doses of CTX310 administered intravenously to 15 participants with familial hypercholesterolemia, elevated triglyceride, or mixed dyslipidemia on maximally tolerated medical therapy. participant pre-medicated with corticosteroid and antihistamines randomized to 0.1, 0.3, 0.6, 0.7, or 0.8 milligram per kilogram of CTX310 infused over several hours. Safety and tolerability assessed during follow-up with biomarkers collected to assess lipid effect and liver safety. The primary safety endpoint included dose-limiting toxicities graded using the common terminology criteria for adverse events. The secondary efficacy endpoints included percent changes from baseline over time for LDL cholesterol, triglyceride, apolipoprotein B, apolipoprotein C3, non-HDL cholesterol, and remnant cholesterol. Median age was 53 years old. The 6 participants had clinical atherosclerotic cardiovascular disease. The 6 participants had familial hypercholesterolemia. The median LDL cholesterol level was 155 mg per deciliter. The median triglyceride level was 192 mg per deciliter. Mean percent change from baseline in angiopoietin-like 3 across different doses shown here. Up to an 80% reduction in angiopoietin-like 3 was observed in a participant receiving 0.7 mg per kilogram. Mean percent change in angiopoietin-like 3 over time shown here. The level dropped on day 15 and sustained up to day 30. Mean percent change from baseline in LDL cholesterol and triglyceride across different doses shown here. Up to an 50% reduction in LDL cholesterol and 55% reduction in triglyceride were observed in a participant receiving 0.8 mg per kilogram. Mean percent change in LDL cholesterol over time shown here. The LDL cholesterol reduction effect was sustained up to day 90. Similarly, the triglyceride reduction effect was sustained up to day 90. Mean percent change in apolipoprotein B and non-HDL cholesterol shown here. Up to an 33% reduction in apolipoprotein B and 50% reduction in non-HDL cholesterol were observed in a participant receiving 0.8 mg per kilogram. Up to an 62% reduction in apolipoprotein C3 and 42% reduction in remnant cholesterol were observed in a participant receiving 0.8 mg per kilogram. When it comes to the safety endpoint, there was no dose-limiting toxicities. No serious adverse event related to CTX310 was observed. There was one participant who had an elevation in liver enzyme, and there was one death occurred in a participant 6 months after treatment with the 0.1 mg per kilogram dose that was deemed unrelated to the interventional product. One participant with elevated baseline aminotransferases experienced the transient aminotransferase elevation without concurrent bilirubin elevation between 3 and 5 times their baseline, peaking on day 4 and returning to baseline by day 14. There were no elevation in alkaline phosphatase and total bilirubin, meaning no severe or irreversible hepatic injury. Let me introduce two cases with CTX310. One is a heterozygous family hypocholesterol patient who had cabbage, history of MI 2 times, and hypertension. He had received maximally tolerated lipid-lowering therapy, including rosuvastatin 40 mg, ezetimibe 10 mg, and evolocumab 420 mg per month. CTX310 resulted in 77% reduction in LDL cholesterol and 53% reduction in triglyceride that achieved lipid treatment target. Second case is severe hypertriglyceridemia patient who had a PCI, cabbage, and had received fenofibrate, rosette, icosapent ethyl 2 gram. The baseline triglyceride level was 1073 mg. The CTX310 reduced 63% reduction in triglyceride to 345 mg and 76% reduction in LDL cholesterol that achieved LDL cholesterol target. There are several limitations. The number of participants was very small, and the primary objective of this phase 1 study was safety. The population was heterogeneous, some with high LDL cholesterol and others with high triglyceride. The broad range of baseline values for LDL cholesterol and triglyceride limit efficacy assessment in specific population. Ongoing surveillance will be essential to assess the long-term safety and lipid-lowering efficacy of this interventional product. In conclusion, CTX310, an in vivo CRISPR-Cas9 gene editing product targeting angiopoietin-like 3, can be safely administered to patients to reduce angiopoietin-like 3 levels. Although the study was small, reductions in LDL cholesterol was approximately 50% and triglyceride lowering about 55% in patients on maximally tolerated lipid-lowering therapy. Lifelong reductions in atherogenic lipoproteins can potentially overcome the issue of waning adherence to current therapies. Assessment of efficacy in specific populations will be feasible in further trial. Thank you very much.
Thank you very much, Dr. Cho. So this is a very nice overview and for the study that was presented at American Heart. Can I maybe just ask if Satoshi would like to maybe jump in with any of your comments and start the discussion for all of us here?
Yeah, Dr. Cho, thank you for excellent presentation. Yes, this drug is looks very new and the results are very well. And I have several questions regarding this drug. So this drug is administered intravenously. So how often should we administer this drug to maintain this efficacy? So how often should we administer this drug intravenously to maintain the efficacy of lipid lowering?
This product is administered one time. Yeah.
So in lifetime?
Yeah, just one time. Yeah.
Oh.
Yeah.
So unlike other drugs like PCSK9 inhibitor or something like that, so only one time injection can achieve lifelong effect on
Yeah, right. By the permanently disabling of the angiopoietin like 3 gene, permanently disabling of this gene. Yeah.
Oh, that's very interesting. And I have another question regarding the efficacy of this kind of drug. So we all know that reduction in LDL cholesterol can achieve reduction in males in patients with atherosclerotic disease. But this drug also has the effect of triglyceride lowering. But previous studies show that the efficacy of triglyceride lowering does not consistently result in the reduction in cardiovascular risk. But do you think this drug can achieve the reduction of cardiovascular outcome in addition to the degree of LDL cholesterol lowering? Do you have any thought about that?
Thank you for great comment. I agree with your point of view that there is some comforting result on the efficacy of triglyceride lowering therapy in the some clinical trials. But the angiopoietin like 3 act as is kind of a fat traffic controller. Yeah. So by inhibiting two important enzymes, lipoprotein endothelial lipases, resulting in the increased level of atherogenic lipid particle. So disabling of angiopoietin-like 3 gene result in the broad decreased level of all kind of atherogenic lipid particles, so that we can get the decreased level of lipid, LDL cholesterol and triglyceride, and apolipoprotein B and remnant cholesterol also, apolipoprotein C3 also. So I think at the moment, LDL cholesterol is not the only atherogenic particle. So this CTX310 can result in more effective the clinical efficacy in reducing major cardiovascular in patients with dyslipidemia, I think.
That sounds great. So thank you very much for your presentation.
Yeah, and thanks, Satoshi, and can I ask if Dr. Kitahara, do you have any questions or comments too?
Thank you for your nice presentation. I have two questions. The first is we can use angiopoietin 3 antibody. So the efficacy of ANGPTL3 monoclonal antibodies is very but some variation. One person dramatically reduced LDL-C, but one person has almost no change in LDL-C level. Is there any variation in this trial? Of course, and a small number of patients is a limitation. And the second question is, is there any possibility to stop the lipid-lowering therapy in medication? So one-time treatment is very attractive. Not taking medication is also attractive. So is there any possibility to take no medication like statin or ezetimibe? What do you think?
Thank you. Very good comment. The first comment, I understand there are also the variation in the efficacy of lipid lowering in this small study. Yeah, I understand. So I showed two cases. that have the profound effect of LDL cholesterol, but other cases might have a little LDL cholesterol lowering effect. When it comes to the second point, I think it's very important. Yeah, in this trial, the CTX310 was administered in patients who have already on maximally tolerated lipid-lowering therapy. But this interventional drug resulted in very profound LDL cholesterol lowering effect. So in the future, we can think about administering this drug in patient without maximally tolerate lipid-lowering therapy. So yeah, that might be the future the research item, I think. Yeah.
Thank you.
I thought maybe with those questions, it's good to, as we have an audience online, just to say that this is a very exciting new area of therapeutics with gene editing technologies. The CRISPR-Cas9 technology is a very elegant way of, you could say, targeting genetic material to change. How do I put it? The culprit, if you have it, genetic material, and create a lifelong lasting effect. And this is, of course, something that is a double-edged sword, because in being able to remove or alter the angiopoietin-like protein 3, you essentially confer on this patient a very lifelong LDL and triglyceride levels. I guess one thing that I wonder whether y'all would agree is that would there be unintended consequences now in the paper which was just published in the New England Journal of Medicine, which I have it in front of me here. That one death, although is felt to be unrelated, does nonetheless cause worry because of unintended side effects or off-target effects. So I think that before it enters mainstream, we will probably need a larger body of evidence. And I would say that this is, of course, in the context of competing technologies, whether it's a PCSK9 inhibitor or a short interfering RNA technology or any number of other RNA therapeutics that are currently under trial and I suspect will have results released in the next few months, if not years. So this is an exciting area that we should keep an eye out for, and one reason why we asked for this particular study to be presented in today's webinar. To everyone, I was just wondering whether you found interesting the different dose effects. The drug at the 5 different dose effects. At the 2 lower doses, there was no efficacy, and at the higher dose, it is interesting that there were some differences. So I wonder whether there's a threshold that the drug would be effective at. It's just rather peculiar that the 4th dose had the least effect, while the 3rd dose appeared to be a pretty good effect. Do you think this is just within a range of error, or is there anything else we should read into this?
Oh,
Sure.
yeah. Yeah. I know that the lipid-lowering effect begins with 3rd doses of drug, the 0.6. But there are 5 different doses: 0.1, 0.3, and 0.6, and 0.7, and 0.8. So I think at least 0.6 doses is the enough to have the positive effect in lipid-lowering therapy, I think. Yeah.
Yeah. And I think, maybe just to transition to our next speaker, I thought the other reason why there are still unanswered questions about this technology is because, at least for now, it is irreversible. I'm sure somebody smart will come along and say that, I can fix it with another gene editing technology. But for now, as far as I know, it's non-reversible, which I think for many of us remains something of a worry because you would want to see longer term results so that there's a better understanding of side effects and adverse effects, etc., before one permanently edits one's genes. But I must say that Dr. Cho, your presentation was very clear and it was very helpful in helping us understand the promise of such gene editing technologies in treating patients with dyslipidemia, especially as a single dose agent that has the ability to remove any concerns about subsequent medication compliance. So maybe with that, it's if everyone is okay, we can now move to our next speaker, Dr. Satoshi Kitahara, and he's going to talk about the second study. Dr. Kitahara, please.
Thank you, Dr. Yao.
Yeah, we can see your
Yeah.
slides. Thanks.
Okay. Good evening, everyone. I'm Satoshi Kirihara from Japan. First, I appreciate Professor Yao and Dr. Satoshi Honda for giving me this great opportunity. Thank you. My presentation is about Vesalius CV study from Bovla et al., which was presented at AHA 2025 and published in New England Journal of Medicine simultaneously. Then no CY. Background. As everyone knows, LDLC is a well-established modifiable cardiovascular risk factor. Statin is a primary drug for preventing CV events. Now we can use PCSK9 inhibitor. The efficacy of PCSK9 inhibitor for reducing the risk of CV events has been already established. The representative trials are Fourier and Odyssey outcome trial. However, clinical benefit of PCSK9 inhibitor in patients without a prior MI or stroke is unknown. In ASCVD continuum, Fourier and Odyssey outcome targeted the major ASCVD events in this population. And they have already had major ASCVD event. The subject of Vesalius CV trial included these stages: high CV risk and atherosclerosis without prior event. This trial was dedicated CV outcomes trial that tested whether evolocumab treatment would lead to a lower risk of a first major CV event than placebo among high CV risk without MI or stroke previously. Trial design is shown here. This is an international double-blind randomized placebo-controlled trial. Subjects were enrolled from 33 countries. Finally, 12,257 patients were analyzed. Over a median follow-up of 4.6 years, 98.7% of patients successfully followed up for primary endpoints. Let's take a closer look at the inclusion criteria. Ages were 50 to 79 years. Baseline LDL-C above 90 mg per deciliter or non-HDL-C above 120 mg per deciliter or ApoB above 80 mg per deciliter. The patient has a history of coronary revascularization with much vessel coronary disease. And prior significant coronary disease without prior revascularization, and coronary artery calcium score over 100. Cerebrovascular disease includes prior ischemic attack, significant carotid artery stenosis, and prior carotid artery revascularization. Peripheral artery disease includes 50% or more stenosis in a limb artery, history of abdominal outlet treatment, and ABI below 0.85. High-risk DM includes these criteria. And they need to have at least one of the following criteria. Exclusion criteria is shown here. Low EF or NYHA 3 or 4 heart failure was excluded. Previously received a CETP inhibitor or any other therapy to inhibit PCSK9 was excluded. Patients were randomly assigned in a 1-to-1 ratio to receive evolocumab or placebo. Primary endpoints was 3-point MACE. It's composite of death from coronary heart disease, MI was ischemic stroke. And another primary endpoint is 4-point MACE. It's 3-point MACE plus ischemia-driven arterial revascularization. Secondary endpoints were shown here. These endpoints were analyzed pre-specified hierarchical order. Overall, 12,257 patients were divided. Patient characteristics are well balanced. Median age is 66 years old. About 40% were female, and high prevalence of hypertension and diabetes. Qualifying disease categories are shown here, and the details are on the next page. 45% of subjects have coronary artery disease. 1/3 of patients has a history of prior revascularization with large vessel disease. 10% of subjects have cerebrovascular disease, and 70% had PAD. With regard to lipid-lowering therapies, over 70% had taken high-intensity statin or a combination of statin and edoximab. Median LDL-C was 122 mg per deciliter. This is the result. At week 48, median on-treatment LDL-C level was 45 mg per deciliter, and mean percent change with evolocumab as compared with placebo was -55%, and mean absolute difference of -63 mg per deciliter. Evolocumab therapy led to significantly lower risk of 3-point MACE. It's composite of CHD death, MI, or ischemic stroke. Its relative risk reduction was 225%. This Kaplan-Meier curve appears to show a larger difference over time. In subgroup analysis, the clinical benefit of evolocumab therapy appeared to be generally consistent, even in qualifying disease category. Similar efficacy was also demonstrated for 4-point MACE. It's composite of CHD death, MI, ischemic stroke, or ischemia-driven arterial revascularization. its relative risk reduction is 19%. Subgroup analysis is also consistent. These results are consistent with the previous meta-regression analysis for statin therapy. Evolocumab therapy also led to significantly lower risk than placebo with a majority of the secondary endpoints in the testing hierarchy, especially 36% risk reduction in myocardial infarction. However, deaths from coronary artery disease did not reach statistical significant differences. Because of this result, results for the remaining secondary endpoints in the testing hierarchy should be considered exploratory. Although the p-value was nominal p-value, deaths from cardiovascular cause and deaths from any cause were significantly lower in the evolocumab group. The results for the cholesterol treatment trials collaboration defined endpoints of major vascular events are shown here. Evolocumab therapy led to 35% and 27% reduction in major coronary events and major vascular events. In the safety endpoints, no evidence of a between group difference was seen. Discussion. In patients at high CV risk without prior MI or stroke, addition of evolocumab to baseline lowering therapy results in 55% LDL-C reduction, 23% reduction in 3-point MACE, 19% reduction in 4-point MACE, and 36% reduction in MI. To date, PCSK9 inhibitors have been studied in the highest risk populations. The findings presented here support the use of the PCSK9 inhibition to prevent first major cardiovascular event in the population along the atherosclerotic cardiovascular disease continuum that is a lower risk than population previously studied. Here, we compare 3 clinical trials about PCSK9 inhibitor. In Fourier trial, about 80% of MI patients, and in Odyssey outcome trial, all patients had prior ACS. The difference from the trial is that the Besaria study population appeared to have a higher population of women and higher baseline LDL-C level. In efficacy endpoints, all 3 trials demonstrate PCSK9 inhibition led to lower risk of cardiovascular endpoint. This figure is from Stefan Nichols' slide. Several imaging studies demonstrated that intensive lipid-lowering therapy led to plaque stabilization and regression. These effects also occur in patients without a history of myocardial infarction, suggesting a reduction in cardiovascular risk. This is from ESC guideline for dyslipidemia. This guideline specifies treatment goal for LDL-C level based on risk. Fourier and Odyssey outcome patients fall into the very high risk group and the extreme risk group. On the other hand, Besaris CV trial patients belong to the high or very high risk. Their target LDL-C level are below 70 or 55 milligram per deciliter. The median on-treatment LDL-C in Besaris CV trial was 45 milligram per deciliter. these high or very high risk patients may need to achieve lower LDL-C level. Limitations. This trial included a subset of patients with less intensive or no background of lipid-lowering therapy. However, the benefit of evolocumab therapy appeared to be consistent regardless of the intensity of statin therapy or ezetimibe use. The percentage of patients taking high-intensity lipid-lowering therapy were greater than those observed in multiple registries. The second limitation is the vast majority of the patients were white. Conclusions. Guidelines have progressively recommended the LDL-C goal of 70 or 50 milligram per deciliter in very high-risk patients, and most recently under 40 milligram per deciliter in extreme risk patients. The reduction in meds seen in Besalis CV with an achieved LDL-C of around 50 milligram per deciliter in the evolocumab arm supports intensive LDL-C lowering to this level, even in patients without a prior major ASCVD event. Thank you for listening.
Thanks very much, Dr. Kitahara. And again, maybe we can call upon Dr. Honda. What are your thoughts when you saw this trial and having this presentation?
Yes, thank you, Dr. Kitahara, for a great presentation. So yeah, this trial is very interesting and important. So based on the prior studies regarding PCSK9 inhibitor in patients with high-risk subjects such as ACS, LDL lowering with PCSK9 inhibitor consistently showed the benefit. But this Besalis trial extended the efficacy of intentional LDL lowering in broader spectrum subjects, including a patient with stable coronary disease without the history of MI or stroke, and those with high-risk DM. So this result is very important because in patients with stable coronary disease, for example, invasive ischemic trial did not show any clinical benefit, significant clinical benefit of invasive strategy in stable coronary disease. But this trial shows that greater LDL lowering with PCSK9 inhibitor result in the reduction in cardiovascular events, including although that statistically this trial is just extraordinary result, but all-cause death as well as cardiovascular death was significantly lower in PCSK9 inhibitor groups. So based on this result, this only LDL lowering with PCSK9 inhibitor may be better than just do invasive strategy in patients with severe coronary disease. So do you think, Dr. Kitahara, do you think that this result would be reflected in clinical guideline of patients with stable coronary disease? Do you have any thoughts? Yeah.
Thank you for your comments. I also this result is very it has a very high impact. So in our clinical, so of course the lowering LDL-C is the best way, but the target patient is very variation. So very frail patient and very young patient, and which patient is very suitable for this PCSK9 inhibitor is unknown. So in clinical practice, the PCSK9 inhibitor use is the very strong weapon to defeat the ASCVD events. I think that, of course, we use more aggressively, but cost is also a very strong limitation. So maybe guidelines, especially in ESG guideline, may change the target LDL-C level due to this result. But in clinical, the use of PCSK9 inhibitor is more frequent. Is where the PCSK9 inhibitor use is increase or decrease. Increase is not sure, I think.
You know, one of the insights I had reading that study is that in the past we have reserved these very expensive drugs for secondary prevention, and indeed that was what the Odyssey, Fourier, and other studies have suggested. But now, in line with the whole concept of the continuum of atherosclerotic burden of disease, I think this is one of the first studies that show that the early use of a PCSK9 inhibitor before a stroke or infarction occurs can change clinical outcomes. And as you pointed out, Dr. Kitahara, the curves appear to continue to diverge. So I think this would, if also shown in other studies with other PCSK9 inhibitors or with the short interfering RNA technologies, then it might transform the way we practice, where we are even more aggressive than now, even for primary prevention, which has a lot of implication for our healthcare systems and also offer an opportunity to reduce the burden of ischemic heart disease in the general population as a primary prevention tool. So I think this is actually a very important study because it is I think, one of the first studies to have shown this particular effect. Maybe I can also ask Dr. Cho, do you have any other comments that you would like to share about this particular study?
Thank you for great presentation, Kitara. I have one question, that how many ASEAN patients were involved in this study, and whether there were any difference in the benefit of Evolocumab in this study between ASEAN and Western population. Yeah.
Wait a minute, please. I check the supplement. Oh.
I think that while Dr. Kitahara checks, these were mainly in white patients, and we probably will have to, I'm sure there are some Asian patients there, but probably the numbers are not enough, and we will have to have some of our own studies as well. I'm also curious as to, and I don't remember seeing the data for this. Do we know if what proportion of patients have LP little a measured, and whether these levels were also whether they, what kind of clinical characteristics? Of course, in a way, it's a moot point because it will be an interesting subgroup analysis, but I'm sure it is a moot point because of the randomized nature of this study. Yes. Can I ask if there are any other comments, Dr. Honda, that you might maybe want to highlight, or does Dr. Kitahara have any when you're ready with? We can ask
Dr. Cho, the Asian patient included 5% in both groups. Thank you.
5% in both groups. Okay.
Yeah.
And can you show that hierarchical outcomes slide, which was rather interesting? The study had two primary composite endpoints, one with clinically driven, what was the word they used? Clinically driven revascularization of some sort, and then the other one did not have any, was just for the composite of cardiovascular death and MI or ischemic stroke. So I was curious about the hierarchical. Could you show that slide, please, Dr.
Okay.
Kitahara? Dr. Honda, in the meantime, do you have any additional comments?
Yes. So regarding the your question about LP small a level in this study, the level of LP small a was not presented in
Yeah.
paper, but okay, Dr. Kitahara.
Yeah.
What?
There's no data about LP small a.
I see. Okay. Probably have to, I'm sure it'll be presented at some point in the future, but I couldn't remember, yeah. But if you there's a slide on the hierarchical composite endpoint in which, yeah, this one where there's a pre-specified hierarchical order in which since death from coronary artery disease was non-significant, I presume that's the reason why the rest were not analyzed, right? But this is of course hypothesis generating, and I'm sure the statistical sleuths will have a few days trying to make sense of it. I guess as a layperson looking at such data, the results with both primary endpoints being statistically significant and with 25 and 19% reduction respectively appears to be clinically significant. Maybe just to ask everyone here, do you think this is enough to change your practice, or do you want to look at cost effectiveness data before you start doing so?
Yes, may I have a question? May I have a comment? Yes. Yes. So,
Yes.
we all know that use of PCSK9 costs a lot, but for example, invasive strategy like PCI also costs a lot. So, because this trial showed the great reduction in all kind of cardiovascular risk, I would say if patients have high risk of future cardiovascular events like this study population, I would recommend the use of PCSK9 inhibitor if patients have enough money to cost this kind of drug. I would I think this drug is better than invasive strategy based on this Belarus CV trial. So of course, in the future, we need to think about the cost benefit balance, but this result may be good future, may provide good future direction in the management of stable coronary disease.
Yes, I also agree with Satoshi Honda, and I expect the cost of evolocumab and the use of evolocumab is more widely used in the based on this study, including the patient at high risk without MI or stroke, and I expect the cost of evolocumab is coming down. Yeah, so yeah, I would strongly would like to recommend evolocumab in patient at at high risk without MI or stroke based on this trial results.
はい。 I also agree with the two doctors. The cost-effective study is also needed. And this trial, the baseline LDL-C level is relatively high, especially regardless the use of high intensity and ezetimibe. Its mean LDL-C level is 115. So I wonder the use of PCSK9 inhibitor for high-risk patients if they have a LDL-C level between 70 to 100 is same effect. I want to need the results, I think.
Yeah, I think I agree with everyone here that this is an impactful study, and the question of whether one would pay for it or whether our healthcare ecosystems can pay for it, I think would need a fairly robust population level health economic analysis as well as a cost effectiveness analysis. I mean, obviously, because currently it remains an expensive drug, and of course there will be questions as to whether a similar level of lipid lowering, if one uses a different agent such as a short interfering RNA agent, may also confer similar benefits. So these cost effectiveness and population level economic as well as population level impact analysis, I think will be important. So I think this makes for exciting and interesting times, because we would, if we can replicate these results with other similar studies, then it has substantial implications for all of us in primary prevention. So I think this is an important study. Are there any comments from anyone else before, as we come to the end of the hour, before we close today's webinar? If not, then I think perhaps it is again really wonderful to hear these two studies that were presented at the 2025 American Heart Association meeting being re-presented here, and for the discussion that we have just heard. So these two studies I think are impactful in different ways. The first one, I think, is the first study that has shown a gene editing technology with the Cas9 CRISPR technology, or what do you call it, CRISPR Cas9 technology, editing out the angiopoietin tree protein and reducing cholesterol levels. It's obviously impactful. The question is, are there any adverse effects? What are the downstream consequences? And can we be sure about the safety? But potentially a very dramatic impact in terms of patient adherence to medications. And the second trial, I think, reaffirms what we know to be the continuum of the effect of LDL and lipids on the atherosclerotic continuum. And in these patients, for primary prevention, albeit at high risk factors, lipid lowering for LDL with a PCSK9 inhibitor has been shown in this particular study, the Vesalius CV study, to be reducing major cardiovascular effects with its two primary endpoints. And I think that will have a substantial impact on how we practice, especially in primary prevention. So again, on behalf of the Asia Pacific Cardiometabolic Consortium, and again, in appreciation of the Taiwan Heart Foundation for supporting this, I'd like to thank our speakers, Dr. Kitahara and Dr. Cho, as well as our panelists, Dr. Honda, for being here with us tonight and sharing their expertise. Thank you very much, and have a good evening ahead. Thank you.
Thank you.
Thank you.
Yeah.